One of the things to think about when we talk about health policy in the future is that, and health administration in the future, is that we've got sort of different forces at work that are going to interact together and that we're going to have to deal with all at once. Good thing we're good at this. And some of those are sort of the social and demographic forces. So we're moving more towards chronic illnesses. We're going to have more older individuals in the system. They're going to produce greater demand, older individuals for chronic care and then long-term care services. We also see that we have more people from diverse backgrounds. So sort of cultural barriers and language issues are going to be a difficulty that we need to overcome and address. Otherwise, the quality of care will not be there. Also, personal lifestyles and this sort of patient autonomy and patient responsibility is slowly coming along, and that will also be a force. There's also economic forces. We're seeing people who are unemployed long term or they're going from job to job. We're also seeing that the financial capacity of the U.S. to provide healthcare, quality or not, is going to be somewhat stressed and strained. We also see more of a globalization, so healthcare can come from all over. We can have people who are in India reading the radiology and being part of our healthcare team, so it's a global workforce. We need to make sure that we also know how everyone is qualified, no matter where they're at, so we get that quality underpinning to everything we do. Also, when we have more globalization, disease, communicable diseases especially, could be in our country in less than 24 hours. So we sort of have to understand how we interact with the rest of the world, not as an isolationist aspect, but in a reactive, we're in a partnership with this, and what happens over there could happen here. So we need to care about outbreaks in other countries. Another thing we need to think about is the political forces. We have numerous issues like healthcare delivery, access to care, specifically for people who would be called so-called vulnerable populations, and we have to make sure that they have access to the same things, not just to a type, but the same quality and quantity of healthcare as other people do, no matter how they access and pay for their healthcare. We also need to think about things such as qualifications. Is everyone qualified in the same way? Do we need to expand the qualifications, expand the education? Because there's actually more to know, as you know from when we talked about technology. There's more and more and more and bigger and bigger. Technology, speaking of which, is moving towards sort of promoting self-reliance for the patient, or at least making them a partner in this process, and that will affect how we use it and how the patients react to it. But again, remember that every time we do technology, it increases cost. So it has to be accompanied by utilization control, or that expansion in cost has to mean that we get better outcomes. You can't just do one versus the other. We're also going to have things like I said, global consequences of disease and natural disasters. So as you've seen, hurricanes and the health issues that we don't usually have on a regular basis, how do we react to those in a proactive way as opposed to just reactive? And that's a big deal. One of the things, too, I want you to think about when we think of health policy and health administration is that there's these little bitty sort of test things that happen other places. I mean, sort of the ACA didn't happen in a vacuum. You had the Oregon Health Plan where the state said, we will make sure that we subsidize people with pre-existing conditions. We will expand it, Medicaid. We will make sure that everyone is enrolled. We will make sure that they're in managed care. We'll ration what people can or can't get based on a priority list, which the entire state came to an agreement upon. And the ACA sort of expanded that and took from that plan, and that worked really well in Oregon, and they then said we will make sure that Medicaid is expanded to all the people uninsured based on financial need. State funding also means that people with pre-existing conditions weren't limited in who could be covered, not just at the state level in the Medicaid and Medicare, but also expanding out to all providers, so getting that minimum standard. It also created a program where we had to mandate that people since 2014 couldn't be excluded because of pre-existing conditions. And again, that came from the Oregon plan that was just a Medicaid plan, but we expanded upon it in the ACA. Then there was the Massachusetts plan, which I've talked about endlessly, and it was actually a very conservative plan, and it's almost identical to the ACA, which is one of the reasons why it's kind of ironic that the political forces who are very conservative are against it, because it was from the Heritage Foundation, which is one of the most conservative think tanks there ever was, and it's very much based on an individual mandate, which means you have to have healthcare coverage or you face a penalty. And what that does is it expands the pool of people to a lot more healthy people who are not going to cost much, and they can offset the people that we need to take because of pre-existing conditions who might be sicker people. Um, we also make sure that there's an employee mandate so that we don't have and that tax penalty. If you don't do it, you get a tax penalty, because we don't want a free rider problem in the sense of, well, I won't get covered because I'm not going to cost that much, which is what we saw with young people in the Massachusetts plan as the people who were the most undercovered. We also make sure that access and affordability were tied together. So it's not just like you have to get it, but also if you can't afford it, we have subsidies. The ACA has subsidies, and again, that came from the Massachusetts program. And what those subsidies are is that was anybody at 400% of the poverty level could get a subsidy as part of their plan, and they had specific minimum standard plans that came with it. So instead of like in the Massachusetts one where a specific connector purchased the health insurance, we let approved plans be sold at the ACA. But again, that came from the Massachusetts with the connector plan. We also mandate that you have to have a minimum level within each program and that you have transparency in what is or isn't covered. Now, what's ironic about that is that these sort of insurance exchanges might have more transparency than yours with a third-party payer. There's still always going to be a large number of people who are uninsured that had to gain access, and they did gain access to basic health coverage. There was also, that means then that we have people who are new in the system, but we didn't automatically expand and have lots of primary care physicians, which you need when you're doing a managed care system, as we talked about a couple weeks ago. And they're those gatekeepers to determine what gets happened and what doesn't get happening and who gets to go where, specialists and such. So it can create a bottleneck. We also, because we've included previously insured people and we've included a lot of preventive health that is now no copay, we're going to have an expansion of that demand. One of the things we need to do as healthcare administrators is see that we expand the primary care physicians and or who can be that, so a lot of mid-levels and that gatekeeping, and that we get a greater engagement with consumers about their own health. And we've sort of talked about how we make them partners and how we might have to train them in order to get them to understand that. So we can't just provide a health portal, we also have to have them understand how that connects with them and provide that sort of infrastructure so they can understand those things coming through. We also need to get more doctors and nurses and other mid-levels trained in wellness and primary care version of care versus you come in for an incident-based illness, which is why our people are currently being trained as. And one of the things that the ACA, and we talked about last week in technology, is its patient activation. And what are some of the challenges there is that sometimes people don't understand how to manage their own health, and they've never had to before, so why would they, whether they had insurance or not? And we have to make sure that they are able to appropriately utilize healthcare to get better outcomes, not just because it's there, but because we want them to get better outcomes. So there's a moving target where we want them to get. Some of the challenges that we face is that, and we talked about this again in class and online, some of you talked about this in your posts, that patients, their own mindset determines what they're going to utilize and what they're not. And they might doubt or question the primary care physician, and that can affect how they actually want to manage their own health, right? Well, they don't trust you, so they're not going to do what you say. So again, that sort of trusting relationship, that real partnership needs to be built into this system. Also, we need to make sure and understand that different people have different levels of understanding and different access to different community-based things that can help improve their health status. And when we make a plan for them and when we want to activate them, we need to make sure that part of the plan is understanding where they're at and what their resources are. And either we increase the resources or increase their knowledge or both so that they can really get to where they want to go. We need to close the gap. And sometimes we can do it through technology. Sometimes we have to do it through talking to people longer and sort of refocusing them at each time and being able to provide some community-based resources so that they can do what they need to do with their own health care. We also need to make sure that we expand mid-levels, so that's nurses, extended physicians, physician assistants, all kinds of people. One of the things we have to make sure is that there's uniformity in their training, and if they're trained in the preventive model, not just in the reactive model or the illness-based model. We also have to make sure that they and the physicians understand that partnership so that we have people working with. So if it's a community health worker or a nurse and a physician, that they understand that they are commingling and making that patient's health better, not I say this, you do that. We have to make sure those understandings and that ability to work together is built in. We also have to make sure that we use information systems, informatics, to build better data, to give them better information about evidence-based medicine so that they can provide the best care for that type of patient. All these things are very, very, very important. Um, Primary care physicians need to have their training changed so that their comprehensive approach is different. They need to be able to anticipate and prevent and then manage really complex illnesses and patient problems. They also, pharmacology is getting more complex, so they need to understand how to do that. They also need to understand, and we talked about this in medical ethics last semester, those end-of-life issues and medical ethics. More of that has to be built in. And again, some of this is what we have to bring. So we have to bring that training to them in a way that they can get. It isn't like they're going to go back to school and do it. So as administrators, we bring that to them. We also have to help them understand coordination of care and understand some of the commingling so that we have a really great medical team, patient-centered care, medical home type model. Again, we may have to provide that training more than once so that everyone understands that. Meanwhile, we have people coming in and there's a shortage of what we need, right? We have older people coming in, we don't have enough gerontologists. We have to think about where's the money coming from. We have to think about changing things, making resources more flexible so we can provide community-based care. Again, we'll need more mid-levels to do that. We also have to think about new infrastructures and the ways that we can empower patients through technology. We also have to train them how to use that technology. Again, the building up of resources that is so, so important. Speaking of technology and clinical resources, we know that that's all going to change very quickly. We've already seen, 3D printers trying to make organs. We've seen genetic mapping. We've seen gene therapy. We've seen therapeutic uses of vaccines to prevent chronic illnesses like cancer with HPV. All of this kind of stuff is moving together very fast, and we may be that person that helps explain it to the provider, who helps explain it to the patient, and we come up with a better medical model. But again, all of this technology has to have a cost-benefit analysis, because it's great to use it because it's there, but it has to add some benefit. It can't be just a cost and we use it because it exists. Cost-benefit has to be built in, and that's where we have to come in and say, this is how much it costs. We don't get much benefit from it. We may or may not provide it, only in these cases. Again, we're going to sort of set those parameters, and an administrator and as a manager, that's one of your responsible roles, is educate, bring the information, but you also have to set the parameters of when you use these things and when you don't, and it has to be based on patient-centered care and cost benefit. It can't just be because their insurance pays for it. It has to have a benefit and do no harm, but add benefit to the patient's life, the patient's outcomes in the way that they define them, not in the way that we define them. Some of the recommendations that we need to do is we have to emphasize evidence-based medicine. We can't just do it because it's there. We have to say that it adds value. We have to look at how we can make evidence-based materials available to practitioners, providers through computer modeling or whatever way that gets them the easiest access, and that we keep building those systems so we can always quantify and we can change evidence-based medicine, or we can see we have new patient population coming in, they need this. So that's that constant collection of data that feeds back into policy recommendations that everyone can have access to. We need guidance and protocols based on those, and we have to be partnered with those providers and those mid-levels and those patients so that they understand why things are changing, why we're doing this, possibly explaining the numbers to them. I know it's crazy and hard to believe. We also have to make sure that if we want to do all these great things, that we also have an impact on the reimbursement, because if there's no money, there's no mission. So if we're changing our mission, we have to make sure that mid-levels are reimbursed for patient education, that we can use community health providers, that we can connect them up with a doctor or a nurse that can also help them in the field, that we have enough supplies in the field so that community health providers can give the best to the community and build up that trust, and if they need, they can move towards the doctor or the nurse, but they don't have to. Basically, we have to sort of bring about a cultural shift in the way we think about technology for the patients, and the way we use it, and the way that the providers understand it. One of the great things about being a healthcare administrator, though, and in this field, is that everything changes so fast, and it can be breakneck speed to keep up, but we get to be part of the change, and the change for good, and the good that can make our communities healthier and people healthier so that they can be their best selves, and that we can make sure that we make and allow and provide so that everyone in the system can be their best selves in helping the patient and the communities live happy, healthy, productive lives, And the underpinning all of this is that everybody should have, no matter where they're born, what community, whether they have insurance or not, has equal value. And that value is to live their healthiest, best life. And we get to be the people who help make that happen.